السلام عليكم ورحمة الله وبركاته. كل عام وانتم بخير ورمضان كريم علينا وعليكم. We start with the lectures of upper limb orthopedics. And the first topics is shoulder and pectoral girdle. And we start with the disorder of rotator cuff or rotator cuff syndrome. We have to know some points about the shoulder anatomy. The main joint in the shoulder is formed by the arm bone and the shoulder blade, or glenoid cavity. The joint socket is shallow, allowing wide range of motion in the arm. So there will be a joint between humeral head and the glenoid cavity. This joint is shallow joint, allowing wide range of motion in the arm, but this joint is potentially unstable. The stability of this joint depends mainly on rotator cuff, which is made of four muscles that surrounding the arm bone. This cuff keeps the shoulder steady as the arm moves. Rotator cuff composed of supraspinatus, infraspinatus, teres minor, and subscapularis. This picture shows the anatomy of the shoulder and the anatomy of rotator cuff. Rotator cuff syndrome or disorder of rotator cuff. We have four conditions. First, supraspinatus impingement syndrome and tendinitis, tear of rotator cuff, acute calcific tendinitis, biceps tendinitis, and or rupture. Impingement syndrome, tendinitis, and cuff disruption. We start with impingement syndrome, اللي هو painful disorder which is thought to arise from repetitive compression or rubbing of the tendon, mainly the supraspinatus, under the coracoacromial arch during impingement position. The impingement position composed of abduction, slight flexion, and internal rotation. So there will be repeated movement in position of impingement. These repeated movement leading to repeated compression or rubbing of the tendons, mainly the supraspinatus under the coracoacromial arch, leading to painful disorder which is called impingement position. This is the impingement position: abduction, slight flexion, and internal rotation. Impingement position presented with pain and tenderness around the shoulder. To start with, subsequently, the progress depends on the stage of the disorder, the age of the patient, and vigor of healing. Subsequently, there will be either subacute tendinitis, chronic tendinitis, and cuff disruption. Either of these depend on the stage of the disorder, the age of the patient, and vigor of healing process. In subacute tendinitis, we have painful arc syndrome. In chronic tendinitis, we have recurrent shoulder pain due to tendinitis and fibrosis. In cuff disruption, we have recurrent pain, weakness, and loss of movement due to tear in rotator cuff. We start with subacute tendinitis, اللي هو painful arc syndrome. We have anterior shoulder pain after vigorous or unaccustomed activity, like competitive swimming or weekend of house decorating. There will be point tenderness just anterior to the acromion process. In this picture, we can see the site of tenderness just anterior to the acromion process. Test for cuff impingement pain. We have three tests. First, painful arc. Second, near impingement sign. And the third, NIRS test for impingement. In painful arc, there will be pain which is aggravated as the arm traversed an arc between 60 and 120 degree of active abduction. So the patient experience pain as it abducts the shoulder joint actively between 60 and 20 degrees of active abduction. Second, near impingement sign. If the scapula is stabilized with one hand, while with the other hand of examiner, we raise the affected arm to a full extent of passive flexion, abduction, and internal rotation. In this movement, the patient feels pain. This is near impingement sign. In near test for impingement, if the previous maneuver is positive, so that's to say near impingement sign is positive, it may be repeated after injection of 10 ml of 1% of lignocaine into subacromial space. If the pain is abolished, this will help to confirm the diagnosis. This picture shows the pain for arc syndrome. In chronic tendinitis, usually the patient between 40 and 50 years of old, there will be a recurrent attack of pain which is settled down with rest and anti-inflammatory treatment. The pain characteristically worse at night, and the patient cannot lie on the affected side and often find it more comfortable to sit up out of the bed. There will be coarse crepitation or palpable snapping over the rotator cuff when the shoulder is passively rotated. This is clinical feature of chronic tendinitis. In cuff disruption, we have either partial or complete cuff tear. There will be refractory shoulder pain with increasing stiffness and weakness, and the patient usually age over 45 years of old. In partial tear, the patient can abduct the arm with pain. هنسميها painful arc syndrome. While in complete tear, the patient cannot abduct the arm actively, while we can elevate the arm passively. So passive abduction is possible, while active abduction is impossible with complete tear. This picture shows the difference between the partial tear and complete tear. In partial tear, the patient can abduct. In partial tear, the patient can abduct the shoulder actively but with pain. While in complete tear, the patient cannot abduct the shoulder actively, but we can elevate the arm passively. For diagnosis of rotator cuff disorder, we need X-ray, MRI, and ultrasound. In X-ray, the changes may be normal in early stage, but in late stage we may find erosion, sclerosis, cystic formation at the site of cuff insertion on the greater tuberosity. We may find calcification of the supraspinatus tendon, but in late stage we may find shoulder joint osteoarthritis. Second imaging for rotator cuff disorder اللي هو الMRI. MRI is the best tool for diagnosis, while the ultrasound has comparable accuracy with the MRI for diagnosing and measuring the size of full thickness or partial thickness rotator cuff tear. This picture of MRI shows full thickness rotator cuff tear within the substance of the tendon. Treatment of cuff disorder, either conservative treatment or operative treatment. Conservative treatment in form of physiotherapy, short course of non-steroidal anti-inflammatory drugs, 1 or 2 injection of dipomodrol into the subacromial space, and protective modification of shoulder activity for at least 6 months. Indication of surgery in cuff disorder. First, if the symptom do not subside after 3 months of conservative treatment. So, failure of conservative treatment for at least 3 months. Second, there are signs of partial or complete rotator cuff tear, especially in young patients. The form of surgery is open or arthroscopic or acromioplasty. شنو الأكروميوبلاستي؟ Acromioplasty is excision of coracoacromial ligament plus excision of part of acromion, which is anterior-inferior part of acromion. By this excision, we give space for supraspinatus tendon to move freely to avoid impingement and tendinitis. Acute calcific tendinitis. This is the last subject of rotator cuff. This is the third subject of rotator cuff syndrome. There will be deposition of calcium hydroxyapatite crystal, usually in the critical zone of supraspinatus tendon, slightly medial to its insertion, occasionally elsewhere in the rotator cuff. The cause is unknown, but may be due to local ischemia. This local ischemia leading to fibrocartilaginous metaplasia with deposition of crystal by chondrocyte. شلون يصير؟ We have ischemia. This ischemia leading to fibrocartilaginous metaplasia of fibroblast and myoblast into chondrocyte. This chondrocyte excrete calcium, and there will be deposition of calcium hydroxyapatite in the area of a critical zone, in the area of ischemia. Clinical picture of acute calcific tendinitis. The condition usually affects the patient between 30 and 50 years of old. There will be agonizing pain in the area of the shoulder. This pain cannot be relieved by usual maneuver or usual modality of pain management. During the acute stage, the arm is held immobile. The patient is usually too tender to permit palpation or movement. In X-ray, we always find calcification just above the greater tuberosity. This is diagnostic, but sometimes we find calcification accidentally around the shoulder, in this area. I mean, in the just above the greater tuberosity. So the diagnosis need clinical picture plus calcification just above the greater tuberosity. Calcification only without a clinical picture does not mean acute calcific tendinitis. Treatment of acute calcific tendinitis, either conservative or operative. In conservative treatment, which is successful in about up to 90% of patients, we have non-steroidal anti-inflammatory drugs, subacromial injection of steroid, physiotherapy, extracorporeal shock wave therapy, and needle aspiration and irrigation. All these are types of non-operative treatment. And about up to 90% of patients relieved by this conservative treatment, but 10% of patients need operative treatment. In operative treatment, we drain the calcific material openly by surgery. حقيقة اللي نتصوره انه الكالسيفيك material is hard material, but in acute stage of calcific tendinitis we find the calcific material in fluid manner. This picture shows the site of calcification just above the greater tuberosity and the maneuver of aspiration and irrigation of calcific material, which is type of a conservative treatment. The last subject of rotator cuff disorder is lesion of biceps. Either we have tendinitis or tendon rupture. In tendinitis, we have pain around the shoulder and tenderness along the long head of biceps tendon, which is passing in the intertubercular sulcus. Sulcus between greater tuberosity and lesser tuberosity. Speed test. We have two tests to elicit the pain of tendinitis. First test is a speed test. And second test is Yergesen test. Biceps tendon, it has dual activity, which is flexion of the elbow and supination of the forearm. In a speed test, we examine for flexion activity of biceps, while in Yergesen test, we examine the supination action of biceps. Treatment of biceps tendinitis, either conservative in form of rest, local heat, or local injection of steroid. For refractory cases, surgery is indicated. Rupture of biceps tendon. Rupture of biceps tendon or rupture of tendon of long head of biceps usually accompany the rotator cuff disruption, but sometimes the biceps tendon rupture is paramount. The patient is usually aged over 50 years of old. While he lifting something heavy, he or she feel something snapping in the shoulder and the upper arm become painful and bruised. If we ask the patient to flex the elbow, the detached belly of the biceps form a prominent lump in the lower part of the arm. Treatment. Isolated tear in elderly patient need no treatment. But if the rupture is part of rotator cuff lesion, especially if the patient is young and active, this is an indication for surgery. Type of surgery is decompression of biceps tendon and repair. And sometimes we need tendon transfer. In this picture, we can see the detached belly of biceps or rupture biceps. If we ask the patient to flex the forearm, there will be prominent lump anterior to in the anterior part of the arm. The last subject in our lecture اللي هو adhesive capsulitis or frozen shoulder. حقيقة هذا السبجكت مو من ضمن الأكيوت or مو من ضمن الكف rotator cuff disorder. This is isolated subject. Adhesive capsulitis or frozen shoulder. There will be progressive pain and stiffness of the shoulder, which is usually resolved spontaneously after about 18 months. The condition is particularly associated with diabetes, uterine contracture, hyperlipidemia, hyperthyroidism, cardiac disease, hemiplegia, and sometimes appear after recovery from neurosurgery. Clinical feature or clinical picture of frozen shoulder. The patient usually between 40 and 60 years of old. There will be aching pain in the arm and the shoulder. Pain gradually increase in severity and often prevent sleeping on the affected side. After several months the pain begin to subside. But as it does so, stiffness become an increasing problem. Continue for another 6 to 12 months after pain has disappeared. The cardinal feature is lack of active and passive movement in all directions. So we have two characteristics: the pain and the stiffness with 3 phases, and lack of active and passive movement in all directions. In this picture, we can see the phases of pain and stiffness, and we can see also the lack of active and passive movement in all directions. The diagnosis. The diagnosis of frozen shoulder or adhesive capsulitis depend on a clinical diagnosis, resting on 2 characteristic features. First, painful restriction of movement in the presence of normal X-ray. Second, natural progression through three successive phases. Natural progression through three successive phases. First phase, pain only. Second phase, pain plus stiffness. Third phase, stiffness only. And then spontaneous resolution. As we said, we need 18 months for spontaneous resolution. We have to differentiate frozen shoulder or adhesive capsulitis from infection, post-traumatic stiffness, and diffuse stiffness. And the fourth condition which should be differentiated from frozen shoulder is reflex sympathetic dystrophy. Infection can be differentiated easily from adhesive capsulitis because in infection we have an inflammatory marker which is ESR, white PC, and C-reactive protein. All these markers are elevated in infection while they are normal in adhesive capsulitis. In post-traumatic stiffness and diffuse stiffness, the three successive phases of adhesive capsulitis are not present in post-traumatic stiffness and diffuse stiffness. While reflex sympathetic dystrophy is difficult to differentiate it from adhesive capsulitis. Actually, it may be a precursor of adhesive capsulitis. Treatment, either conservative or operative. Conservative treatment in form of analgesia, exercise and physiotherapy, steroid injection, local steroid injection, manipulation under anesthesia, and an alternative method of treatment is to distend the joint by injection of large volume, about 50 to 200 ml of sterile saline under pressure. This injection of large amount or large volume of sterile saline, it will distract the contracted capsule and permit good movement of shoulder joint. Surgical treatment is indicated in a prolonged and disabling of restriction of movement which fail to respond to conservative treatment. That's to say, failure of conservative treatment is an indication for surgery. Surgery is arthroscopic capsular release. Thank you and good luck.